people, if they have some unpublished temperature,
Yeah.
your data is already.
And then yeah, thank you for the invitation. Pleasure is mine. And then I defended my PhD, so you can use the my presentation the YouTube or whatever.
Oh, great.
Yes.
Okay, good. Oh, you defended
Cool.
your PhD already. Oh, wow. Congratulations. Yeah. Yeah, well, we
Yeah,
might.
because the last time you invited me to present the Banff automation, in the Nature magazine.
Yeah.
That one at the time I haven't defended yet, so it was a little locked with the
Yeah.
embargo.
Okay.
Yeah,
Well,
yeah,
that's
but
nice.
now it's free to use.
Oh, great. Awesome. Well, we may actually publish, we may put both of them. I actually can find that one. We'll do this one first, but then I can probably go back and find, I have all the record. We only shared, unless somebody, so yeah, we definitely haven't shared it, but we can do that now. But I have a few introductory. Is that okay? Or how long do you think is
Oh
that
yeah,
fine?
go ahead. No, go ahead,
Okay, great. Okay, so I'll just
please.
do a few introductory, and that way it will give people a chance to, if there's some late people, they'll be in time for your talk. But basically, here's my what I was going to show today. So happy Leap Day. I'm glad. I was actually worried that people wouldn't make it today, because I was like, well, is this going to
This
mess up the
date
calendar or
doesn't
something like
exist.
that? But yeah, so thanks for presenting on Leap Day. And yeah, thanks for people for joining. And we're still in the winter theme. I think the next meeting I'm going to try to update the graphics to the spring theme. So hopefully we'll have we actually already have a lot of flowers here, which is good. So yeah, so thanks everyone, and your participation is really appreciated. We thank you for all your ideas, and let me know if there are any speakers or collaborators who we need to be in touch with. I just put this every time almost, but I did edit this slide slightly to give our 4 big aims that we provided to the overall Banff sort of foundation. And our aims are an image bank, a repository, and we have some trials for that, but we want to do a better job. So we actually have a grant with some people on the call now, and so hopefully you're going to build a better image bank that sort of has more features, and the one we have now is great, and we can continue to expand on that maybe with June Kong and other people. And then in the larger transplant community, we want to sort of provide algorithms, the Banff community and even the larger transplant community, some algorithms that they can use, image analysis, and maybe other things. We're going to learn about some great algorithms from Daniel today. And so I really am glad he's able to present. And then, we have a competition or trial or challenge in progress. And we heard about that a little while ago from Dominique, and she's on today too. So thank you so much for all she's doing on that, the diagraph sort of challenge. And she has some great developments on that. She told me she has a name. I won't give away the name, but she actually has a new name for some of the efforts she's doing on that. And then we're going to sort of our last thing is actually something that Kim came up last time we had to report, is the rethinking the innovation timeline. And I don't want to take too much time to go into that, but we can talk about that more maybe next time. And I want to mention the Banff meeting. We want to keep that in mind. It's coming up this September, and so obviously we hope to go to that and be a part of that, and we want to sort of hopefully accomplish some things before that. As I mentioned, we have the grant pending, and so hopefully we'll hear about that before then. So the next meeting is actually, I've kind of left open as sort of a planning meeting, and we can talk about the grant. And then, there's been a talk about maybe even doing another grant, an R or a U grant at the NIH or something like that. So we can talk about ideas for that. And then we'll also maybe talk about the Paris meeting and some things that we do for that. And then we're going to defer the meeting for the USCAP week. I know it's the Thursday after USCAP, but I think people will be traveling, be tired, so we won't meet that week. But then the next week, I actually saw that Sharifa just joined on April 11th. We're going to hear from Sharifa Sahai. And so that'll be awesome. And then we'll actually hear, I was able to pin down, I think she was actually traveling she's very busy, but Priya Alexander, Lynn Cornell, I see she's on and I'm glad she's here, but Priya was able to finally give me a date. I think some of my emails went to her spam, unfortunately, or something. So I was able to get in touch with him. So we have her for the end of April. So that'll be awesome. So I really look forward to that. But today I'd just like to turn it over to Daniel now, and I really appreciate, again, he's coming to us from the Paris transplant group. And he has some amazing work he's done. So I'm just going to turn it over to him. So thank you so much, Daniel.
Thank you so much, Brad, for the kind introduction. And then this is the second time for invitation. Thank you very much. It's really a pleasure to talk this group, Banff group, digital pathology group. And I'd just like to tell you that my project is not digital pathology, but it's a kind of a bridge to fill in the gap between the digital pathology and our traditional biopsy procedure. So I will go for my slide. 1 second. Okay. Great. Can you see my slide? All of you?
Looks great. Yeah, thank you.
A paper is a machine learning driven virtual biopsy system for kidney transplant patients. So in France, we always call it virtual biopsy system. So we're in French. So okay, so everybody knows, but just to start what the virtual biopsy is. So it's of course it's a biopsy performed on the day of the transplantation, kidney transplantation in this case. It's used as a baseline status of the donor kidney performance. So the kidney allograft performance reference for a comparison with after the transplantation. So comparison with the post-transplant pathology. And then, but unfortunately, it is a time-consuming and costly procedure in many countries, and which requires surgical, medical, and pathological resources. You have surgeon on site, etc., and sending over and OPO and to decide and so on with the biopsy result. And so for these reasons, many centers around the world do not perform such day zero kidney biopsies, although the benefits are quite clear. And then even the Banff report, it recommends to perform the day zero biopsy. But it's understandable. So in this study, we made a hypothesis that using basic donor parameters, and it must be from high quality and big data. We would like to translate this data with the machine learning so that we can predict day zero of pathological lesions. So the donor parameters, when I say, these are like really basic parameters like medical history, comorbidities, donor demographics, clinical parameters like proteinuria or like creatinine, and then some machine learning algorithm like all the pipelines. And then we like to predict the day zero histological lesions. So they are the usual suspects, CV, AH, Ip7, of course, and glomeruli in percentage. So this has the potential to save money and mitigate risk associated with medical procedures. Thus, the aim of the study in the end was to develop and validate a virtual machine learning driven biopsy system using donor parameters and to predict the day zero kidney biopsy lesion. So in this study, the design was to include as much as the data possible because the machine learning algorithms are usually the data, big data in favor. So we in donor biopsy, both from living and performed from 2000 and 2021, Australia and Chinese centers. So these centers were 15 centers were included in the development cohort, and two centers were included in the extended variation cohort. So the two centers are, I believe, the Colombia and then Chinese center. So the inclusion criteria were the age at least 18 years old, so no pediatric, and then at least one Banff vision score should be measured in the day at the day of the kidney allograft. And if the number of glomeruli for the biopsy was less than 7, then we removed this as an inadequate biopsy. The explanatory variable all the donor parameters, usual suspect, we included 11 donor parameters. So they are the parameters that we use to train the machine learning models to predict the outcome variables. So they are the donor's age, sex, donor type, living or deceased. And if the deceased donor, the biopsy was from deceased donor, then we also inputted the cause of death, so cerebrovascular death or circulatory death, and history of morbidities, hypertension, diabetes, Hep B status, BMI, low serum creatinine, and then proteinuria status. And the outcome variables were the CVH IFTA, the glomerulonephrosis, as I mentioned, and then we used the semi-quantitative ordinal value, the CVH IFTA, and then the glomerulonephrosis was the 0% to 100%. So we have more than 14,000 day zero biopsies and 12,000 for day zero biopsy for the derivation cohort, 1,600 for external validation cohort, 11 donor parameters, and 4 day zero lesions scores to predict. So thanks to our collaborators, we have big data and rich and heterogeneous data. This is very important for machine learning. I need machine learning algorithms to learn the patterns and even the marginal small patterns that sometimes could be missed with the algorithm. And this slide is very important because many non-machine learning experts could assume that machine learning is just basically one algorithm. So like a random forest, like many people are familiar with CNN or like ANN, artificial neural network, or deep learning network. Well, that's important, but that's only algorithm. So that part that I just mentioned is basically here. So one line, but the other lines are all the data science and machine learning pipeline, and then these are all must be taken into account very structurally and then comprehensively. And then you need to as a data scientist, I cannot really make a decision by myself. Also, I need to interactively the interdisciplinary I need to discuss with my colleagues, which are clinicians and the nephrologists and pathologists. So from the data pre-processing and data collection, we need to build the strategy of the collecting the development and validation forward, and how to handle the missing data, what kind of algorithm to use for imputation algorithm, what kind of balance the data has. The outcome balance, most of the time they're unbalanced. For example, the CV IFTA lesion 0 is much more major than IFTA lesion 3, because we don't really have many IFTA 3 scores. So we try to get gather as much as possible, but it's not really feasible in real life scenario. So that kind of things we need to think about how to handle this kind of problem. And then of course also the numerical data, the creatinine and donor age are in different units, and they are in a different ranges. So we need to handle this kind of standardization, scaling the data. And then also how to tune the model, how to observe the model process, whether it's overfitting or the performance fluctuating or not, and then what kind of methods to use to improve the model performance. And there are many sensitivity analysis or assessment, so to say. So for example, like feature importance analysis to observe whether the model is actually talking completely crazy stuff, or it may be clinically meaningful stuff. So these are all the what we need to observe and then discuss with clinicians and pathologists and the expertise in that field domain. And then of course we also need to take into account the final deployment step, because if I make a very fancy model and then just say we made a very fancy model, AUC 0.9, so it's good, we publish in the AJT, but if nobody can really have access and then use it, then it doesn't really matter in the end. So we want to make it available to the clinicians. That's why we may need to find an easy way for users, clinicians to use the developed model. And maybe in after the deployment, maybe it doesn't really work well in that in their distribution of the data. So for example, if we made a really nice derivation cohort, the model debate and derivation cohort in United States, maybe it's not really working well in Japan. So in that case, we may need additional calibration to that country. So that after the publication, you may need to calibrate further ones. So all these pipelines are very important and then very thorough, like very comparable to the traditional statistical pipeline. And then after all that, here is the result of the performance of the machine learning classifiers and then the ensemble model. So the ensemble models are showing on the bottom line of the table, and this is our final the Piaggio system model. So ensemble models basically aggregate each model probability. So each model we use here 1, 2, 3, 4, 5, 6. So 6 models generate 6 probabilities, and the ensemble models aggregate those results by averaging the probabilities from all 6 models. And in the end, you see that random forest is also very good, but the ensemble models are comparable to the random forest. And then in the external validation, this is a derivation cohort. The result in the external validation, the ensemble model performs more stable than random forest model. So that's why we have all these ensemble models. And this is external validation cohort. The thorough in all cohorts. So the blue ones represent the internal cohort, and then the red and green represent USA and China external validation cohort. And then there are like multi-AUC, sensitivity, specificity, balance accuracy, AUC, ROC, and then mean absolute error and RMSE. And then the mean absolute error, the RMSE, they are errors. So the lower, the better. It's the opposite way to the AUC statistic. So in the USA and China external validation cohort, the AUC for multi-AUC for CVH IFTA are the 0.74 and 0.733 and 0.723 for USA, and then MAE for glomerular sclerosis 5.2. And then for China, it's comparable, so 0.74, 0.736 for CVH, and 0.798, so almost 0.8 for IFTA scores, and then 4.6 for glomerular sclerosis error. So overall, you can say that your derived virtual biopsy system demonstrates a good performance in both internal and external validation. Of course, we can make a very fancy and very complicated model and show that the AUC is great, but we also like to investigate more deeply how the machine learning models are thinking in terms of the clinical parameters. So those are the 11 parameters that we use for the derivation of our virtual biopsy system. And then for CVH, IFTA, and glomerular sclerosis, you can say that you can see that the age, creatinine, and hypertension are very important parameters for CV, and basically it's the same for the all the other parameters for the lesions. So in AH, the cerebrovascular death also very important, diabetes, BMI, and IFTA and glomerular sclerosis. The similar patterns with diabetes, BMI, and hypertension and age. So these are also feature importance average from our individual model. So they're not just one model, and they're individual like ensemble model. And then we validated the virtual biopsy system in different scenarios and populations. And these were done on the derivation board, split it into a region, ethnicity, donor criteria, the extended criteria donor, or standard criteria donor, or biopsy type, pre-implantation, pre-implantation, and post-reprovision. And in general, the virtual biopsy system performs well on various scenarios and subgroup population. In the end, this is the deployment example that I'm including here. So it's available online. If you see the paper in the Nature Communication, it has a link and then some figures in there. So basically, you can go to the online application, which cloud-based, and then they have the models included. And then if you use some those 11 donor parameters for creatinine, you can change the unit if you want, and then it calculates internally. Then it outputs the probability, and then also the hard classification support for 0, 1, 2, 3 for the CVH if the Banff score, and then also with the radar chart for some visual inspection. So in conclusion, we have established for the first time a precise and robust virtual biopsy system in kidney transplantation. This system actually predicts later histological lesion score using only 11 base donor parameters. Has been internally validated in Europe, North America, and Australia, and externally validated in the USA and China. I said this system may assist in interpreting post-transplant chronic lesions, adjusting clinician prognostic judgment, and reducing cost. And as I said, this is not digital pathology. So in our team, Erwan, he's working on digital pathology. So digital pathology is more precise and more like machine-driven than virtual biopsy system. And then it's a quantitative like percentage accuracy. But what I do here is the semi-quantitative, the Banff, our original Banff score. So it is more like a bridge, bridging this gap between now and the future. Thank you very much.
Well, that was great. I really think that was awesome. And it's funny. We've had this talk before about digital pathology and the definition of it, and there's always a lot of debate. But I actually view this as a form of digital pathology. I have a liberal definition though. Some people say, that's only glass slides and then scanned, whole slide images. But some people are really restricted. But I view this as I view your study as you're using computers and you're using pathology data. So I in a way I view that as digital, but some other people say no. But I actually think your study is awesome, and I think it actually people could say it actually fits in that. So thank you so much for presenting that.
Thank you very much.
Yeah, I'll open it to other people. I have some questions, but I'll open it to other people and let them ask first.
Can I ask a question?
Oh yeah.
Oh, sorry. Who's first?
That's okay. You go ahead. Go ahead.
Okay. So at Mayo Clinic, of course, we do the time zero biopsies, and Andrew Rule had been one of our nephrologists who's not interested in transplant. But anyway, he was interested in looking at those time zero and has been looking at those time zero biopsies for many years now and correlating them with various factors of the donors, because these are living donors, by the way. And they've all been because those donors have been evaluated so thoroughly medically, and he basically used that as a model for normal aging in healthy humans, normal whatever aging of the kidney. So did you look at sorry, I haven't read your paper in detail. I saw your paper, but I haven't read it yet.
It's free online.
But so I haven't pulled up so I could read it today. But I didn't realize you were presenting today until now. But so did you look at that? How does it compare to his data? And especially, how does it compare to living donors? Can you draw any conclusions from living donors? And then if I can ask just another question too, for his study, and I was involved in one of the really early studies, but I was always surprised that he was using the Banff criteria, the Banff scoring system, because we already had that data and the biopsies were already scored, and it was kind of already scored in a blinded fashion because we didn't know the age of the donor. Usually we didn't look up the age of the donor. It's just a time zero biopsy, and nobody looks into it that carefully. but I was always surprised that, for the most part, they look normal, especially for the interstitial fibrosis and tubular atrophy scores, because you have to have quite a bit of, I guess, interstitial fibrosis to get a CI score. And then arteriosclerosis, sometimes you would see a little bit, but generally they look normal. And arterial or hyalinosis, generally we don't see. Of course, all these things increased with age. But the thing that was kind of surprising to me was one parameter that I think one parameter was global glomerulosclerosis. And he had used any degree of global glomerulosclerosis as I guess as a nephrosclerosis feature. And anyway, I'm just wondering what your thoughts are on that. I feel like, what am I trying to say? Any degree of global glomerulosclerosis, of course, is increased with age, but it seems like that is more of an early indicator of any of any chronic changes in the kidney, whereas you need more damage, more long-term damage, if that makes sense, to get any of the Banff scores like CV or AH or
So
CI
age
or
was the most important feature for all the lesions, CVH and glomerulosclerosis, of course. And then as we expect, and then for living donor, as the first question, the virtual biotic system was struggling a little bit because you see the cause of death, circulatory death, or cerebrovascular death, cause of death were also very important feature. And living donor, relatively, we don't have that much data. And then because we don't have two features, the cause of death or gone, the virtual biotic system has less power, predictive power for the living donor. So we may need more specific features maybe for the living donors, but we don't have it in this study. We have only 11 parameters, including the cause of death. So for living donor, we had some struggle. And then, virtual biotic system performs better in the deceased donor. For glomerulosclerosis, that one was also quite complicated to predict because we wanted to use the full continuous lesion, the glomerulosclerosis 0 to 100%, but because some are like 80%, 90%, 100%, 70%, but they're very rare. And then we don't really see as so I work with nephrologists, right? And then they don't really even understand why this biopsy with the donor, such donor parameter has like 80% of glomerulosclerosis. So experts don't really get it, but that's the result, right? So we don't really know. And then so we were hoping to find some patterns to have correctly, precisely predict glomerulosclerosis, but it was quite complicated, especially for these very high glomerulosclerosis. But we didn't want to stratify them, group them, categorize like less than 20% of glomerulosclerosis and greater than 20% of glomerulosclerosis, so 0-1 binarizing, because there's not much reference for like what is the most clinically important cutoff. So we used the original continuous the parameter, and then it was quite difficult. And also for the feature importance, and then we what kind of feature is the most important or less important, and then what is the worst having a negative impact or positive impact for the certain outcome. So because we use machine learning, and because it's not logistic regression has a negative or positive coefficient or beta values. And then when you change to odds ratio, you can see that it's greater than 1 or not. But in this case, because we use machine learning, it doesn't really produce this kind of very intuitive way. It just shows you how important they are for these machine learning models, algorithms, predict certain outcome, which is the day zero lesion. So those are the one that I showed, the bar plot figures. But we don't really know that the age, if we increase the age to 19 to 20, then what does it mean to CV score or age score or Goodman sclerosis? It doesn't really directly tell you.
Hey, Daniel, very nice work and very, very promising.
Thank you very much.
So the overall performance of the biopsy system does look very good. But I'm wondering if you calculated the performance for those biopsies which actually are prone to organ discard. Like what's the accuracy for CV2, IFTA2, IFTA3, those, individual calculations. Because most of the biopsies in your collection are mild. So just being able to predict mild is almost expected. Most of them are mild. Well, that's what the system is going to say. No?
So it's definitely true for the more severe lesions, 2 and 3, moderate and severe, is because we don't really have much data. So we have some, we try to collect as much as possible, but still we don't really have. So machine learning models always struggle with these kind of minor classes, and we try to boost the performance for these. So that's why we use, I didn't really mention, but we use upsampling technique to randomly more sampling these minor classes to maximize the performance for these minor lesions. And then yes, yes. So it is true that it's struggling, and then but we wanted to, so the easier way to perform this is the binarizing them, 0, 1 versus 2, 3, because then we can simplify everything, and then we can use just RCAC, and it will be much better. Our life will be much easier. And then we actually included this one in our metric, AUCRC, and also sensitivity, specificity, and accuracy. So for these binary metric, we use binarization, but for multi-AUC, we use all 0, 1, 2, 3. So we use everything. But the if you look at the paper and the figure, the AUC-RC performance is much better than the multi-AUC, which makes sense because we have much more simplification in the algorithm than generalizing using the full spectrum of the Banff lesions from 0 to 3. Of course, if you imagine that if you use quantitative Banff score 0 to 100%, then semi-quantitative, then you'll be much more difficult, like Goodman sclerosis, and then we would have much harder time. So I think right now it's using the semi-quantitative is better than using the 0 to 100%, because it will be very difficult for a machine. And then I'm sure also it means that for pathologists also it's quite difficult to predict whether this is a 35% or 37%, right? So it's right now it is I think the better way, and then in the end with the digital pathology we can reach that level maybe in 5 years.
So my question was that, the AUCs for the overall system are in the 0.7 to 0.8 range. So have you calculated the AUCs taking only the biopsies which have CV2, only the biopsies which have IFTA2? Because those are the biopsies which really matter.
No.
How about like a PBV, right? What's the PBV for this instead of AUC to check the platelet rate for the high CV2, something like that?
So your questions were the predicting the CV2. So CV2 versus other, for example.
I think those figures will be low, and you should generate them because those are the things which are practically important.
Yes, you're right. So multi-AUC include all these. So that's why it's lower than AUCRC. So it includes all these 0 versus others, 1 versus others, 2 versus others, and then averaging them. But we didn't report individually.
And similarly,
you're right. It could be very interesting.
And similarly, you should do the calculations for frozen versus formalin fixed, for needle versus wedge. Are there any figures that you can share with us at this moment?
In the last figure. So in the table, the validation in the different scenarios and subpopulations, we did some sensitivity analysis, donor criteria, but we didn't do the like frozen versus fixed. So we didn't do that. But yes, it could be interesting. But I don't think we have all the details of the biopsy because some are missing in the data set. So if you remove them, we lose all the predictive power. So I think that's why we didn't perform this one. But yeah, all the tissues or the types or techniques or stratification in the sensitive analysis could be very useful. And then yeah, the thing is the main reason why we didn't do that is that this is basically using the donor parameter only, and then to predict the lesions. And then we know that depending on the techniques and depending on all the different tissues or whatever, we have there's some variance. So variability should be taken into account. But the whole concept of the objective biopsy system is we don't know the technique, we don't know. It's just that biopsy, and then we have donor parameters. It's to make it simplified.
So I have a long-standing interest in this area. So I actually read your paper quite carefully with a lot of interest. And so I did actually particularly look at the confusion matrices, and then one of the things I wanted you to comment on is that for biopsies which had an IFTA score of 2, about 40% of the time the system was predicting a score of 0 or 1. And so that to me didn't look good,
Yeah, I understand.
And there's something you should think about
because
to improve the
because
performance.
IFTA is quite unbalanced.
You have to improve the performance of the system before it becomes a practical tool, and whatever effort you can make to get more IFTA tools, to get more CV tools, I mean, you have to get it. Otherwise, the tool will have limited utility,
Yes, you're right. You're right. So yeah, I think so. The project started before I was joining this team, and then the co-founder Dr. Gillian Diva, he told me that he and the team was trying really hard to get the IFTA 2 and 3, but yeah, you're right. The IFTA was the most difficult, most unbalanced one compared to CV and H, and then we didn't really have them so much.
But that's the problem with the whole
I know yes.
This is the problem with the whole field. People say biopsies are not useful because there's an inherent problem in solving the problem. The biopsies which are really bad, well, those organs don't get used. So the machine learning doesn't solve that basic problem.
It's true.
But
so that's a major the major disadvantage, not disadvantage, but you cannot really solve this kind of data problem with the machine learning.
Oh, I put this in the chat, but I thought these were all the time zero biopsies, not donor biopsies. So presumably they would all be just needle core biopsies. I agree. There would be an issue with sampling if you have more, subcortical sampling with a wedge biopsy or more superficial sampling with a wedge biopsy. You might have overrepresentation of global glomerulosclerosis. But I thought that was not an issue here because I thought they were just the time zero post perfusion biopsies, right?
Yeah, so we have a time zero, and then also we have also a pre-implementation biopsy.
Oh, okay. So you included all of them.
Yeah, it looks like your table, supplementary table 14. It looks like
Yes.
a huge mix, and like it's actually interesting. And I think that what Parmjeet said about like substratifying it'd be really interesting in the future because you have a lot of formalin fixed paraffin embedded, which is actually interesting. I haven't looked, and then you do have a lot of frozen also, it looks like. So it's a big mixture of types of biopsies actually. Which
That's
could
true.
it could be really interesting to look at all that separately. But this is awesome. Yeah. Any other
There was one question from Sam Berger. To compare the predictive operation with underlying conditional distribution.
Yeah.
What do you mean by the underlying conditional distribution? What do you mean by this?
So by that, I mean, you have a lot of data that you have to draw on here. Did you ever find that it was the predictive model was more accurate than just descriptive statistics? So essentially what we have here are a lot of conditional distributions for each one of these different these clinical features. What would be the value using a predictive model as opposed to just saying, I have a patient with this set of clinical metadata. Can you show me all the other patients that's similar, or, you know, like
okay.
So someone find all the samples within this range or have similar metadata, do they have, or what is their glomerulosclerosis percentage? What is their time zero lesions?
Yeah, so I think what you're saying is more like a nearest neighbor method. So you have like
just
a
a
3 or
probabilistic.
5. Yeah, yes. So in this study we didn't do that. Well, we can say we used the logic regression, multinomial logic regression, so that could be the closest one. But we didn't use the nearest neighbor technique. And then because this is a predictive study and predictive the biopsy lesion, so the nearest neighbor was not used. But I'm sure that the nearest neighbor would have hard time to predict this, especially the like glomerulosclerosis, because it's quite complicated to predict too. And then the as you can see that our 11 parameters, many are binary, like deceased donor or living donor, or do you have hypertension, or do you have diabetes, and these are not very complicated data. So with the nearest neighbor, it wouldn't be very accurate to predict probabilistically. It's just that's my opinion before actually performing. Yeah.
Sure. One follow-up question. Does your online system tell if someone puts in a set of information, are you able to tell, oh, there are no examples in our data set which match this set of input parameters that you provided? So if someone had a 130-year-old patient, for example, and they wanted to know some of this data, so your model would still render a prediction, even though you have no patients with that available.
So since this is not a nearest neighbor and it's just prediction model, so even if they're not included in the database, so that's the whole point of machine learning prediction. So machine learning should be able to predict something new, something that the model has not seen yet, right? So we can predict whatever the data is, but it reminds me of maybe a mistake that I may have not yet implemented a function that if you input like minus 10 years old, then I didn't say anything. So maybe that one is a little bit mistake. But if you input the 135, it's still pretty. Maybe very high lesion, etc. But it's still pretty.
Yeah, thank you.
Thank you.
Daniel, yeah, great work. Yeah, very impressive data. Actually, I have a few questions. First of all, as I just echo Lynn Connor said, if they are not like if there's a mixture of like a donor biopsy and time zero post like a fusion biopsy, and so the model should include some like a peri-operation parameter like ischemia times, also like if we use a pump into as a covalence. And the second question, because if for the specific for African Americans, some like genetic factor, for instance, like APO1 risk allele is also contribute to like a kidney quality. So in the future, if this genetic information specific for African American population is available, it could be also added into your model as well.
So
Yeah.
the first question is the what about the other parameters like
Yeah,
ischemia time?
like a
And then the second is
peri-operation
the
parameter
affinity.
for the
Yeah,
for
perioperative.
the post
Okay.
for the post perfusion biopsy.
So
And
if I answer yes. Go ahead.
yeah, this that's the question. I think in the future maybe should include for this like a post perfusion biopsy rather than like a procurement biopsies. And my second question is, I look at your parameters for the covalence. Looks like all the top four are the same, like for different outcomes like glomerulosclerosis, CV. I don't know when you derive model because these four outcomes are kind of correlate, right? So I don't know if you develop model, did you like adjust for this like factors? And did you if you did you identify some like factors specific for like let's say glomerulosclerosis or like arterial sclerosis or AV or EFTA?
Okay, so if I start with the first question was the perioperative clinical parameters like cold ischemia time. So it's very people use it sometimes to predict day zero biopsy lesions or glomerulosclerosis, but in this case it doesn't make sense so much because we know that this day zero biopsy lesion is often in the United States, especially, is used for organ allocation also. And then during organ allocation, there is this cold ischemia time is generated, right? And then if we want to skip this process, maybe the virtual biopsy system can be some kind of threshold. But if CIT or perioperative clinical parameters are included in the virtual biopsy system, which means that we cannot use it when we procure the organ. When we procure organ, the CIT is basically 0, and then we need to wait like 3 days or something, some hours to calculate to gather the CIT. But that doesn't really make sense, and it's not our it doesn't fit into our study aim. So if you include this perioperative clinical parameters, then we need this perioperative parameter, but the donor parameters before the donor per se, right? And then the perioperative is after the procurement, and then it happens in the between or the pump or etc. But these are during the allocation process. But if we do not include these perioperative parameters, then we may be able to skip all this peri-operation and then just jump into the allocation directly. So yes, if you include the CIT, if you include some perioperative clinical parameters, then the predictive performance would be better, and then it would be better for the predicting the histology lesion. But for clinical utility, it wouldn't have a very huge impact. So that's why we only include it at the donation time. The second question was ethnicity. So the ethnicity is very interesting factor that we wanted to include in the model. But the problem was that there were a lot of missing data in Europe. So in France, basically it's illegal to collect ethnicity. So in the United States data, we had all the ethnicity, most of the ethnicity data in the United States course. But in many European countries, we didn't have it. And in France, nothing. So basically, it means that we can either all impute or remove France. But we are French, and we are a French institution. We cannot just remove French data. So also imputing like 50% or something is not really favorable. So that's why we decided not to use ethnicity. And the third question, I'm sorry, what was the third question?
So the question is, I found like the top parameters are similar, like for instance,
Yes.
as creatinine and BMI and hypertension. So
Yeah.
I don't know if it's because you didn't adjust for the, because this 4 outcomes basically are correlate, right? Is it because they're correlate, identify similar features?
So that was one of the questions from a reviewer in I don't remember which journal was it. So we tested the correlation among the independent explanatory variables, the donor parameters, and then they were not usually correlated. Luckily, the maximum was I remember CB and AH, but they were both artery, so they're understandable. But it was not 0. Over 0.7, like 0.5, I think. And then nothing was really significant. So we are sure that they're not very significantly correlated. And then also the one benefit of machine learning, not logistic regression. Logistic regression has statistical assumption, but the other machine learning algorithms such as random forest or neural network, they do not take assumptions. So you can just input everything, and then you don't need to care about the assumption. And then you perform all the machine learning algorithm with the big data. Maybe there's some correlation, but you can perform, and then it takes into account all the correlation internally. So you don't really need to take care.
Yeah. So my last question, can I ask one more questions? And
Sure, go ahead.
If you have using your like virtual scores to predict the transplant outcomes and compare to like a pathology score to see which one is better, if your like virtual score is better than the like a pathology score for outcome protein, for instance, graft loss, or like develop EGR post-transplant, not develop like IFTA post-transplant, have you did a comparison for your virtual score versus like actual score?
So I mean, like for prognosis after the
for prognosis,
the survival, like that, yeah. Oh, okay. So we didn't do that. We want to do it in the future because yes. So for example, like real biopsy versus a virtual biopsy, and then a prognosis testing comparison. We would like to do it, and also we would like to do maybe a clinical trial to test whether after like threshold or something for virtual biopsy. So you have a virtual biopsy greater than 1, then maybe you need to actually perform it. Or maybe the virtual biopsy is 0, high chance, then you skip it. So and then you go to the transplant directly. So they're kind of shortening the organ allocation process. We would like to do it, but we haven't done it in this study yet.
That's great. Yeah, we have some like slides. We'll be happy to work with you to see how good your score and compared to our digital score. We have general digital score from slides. We love to collaborate with you to some collaborate. Maybe combine your like visual score with digital score in the future.
So your digital score is a digital slide with the digital pathology?
Yeah, we developed digital pathology method that we presented last time, and we are interested in work with you. Maybe can compare your virtual score with a digital score. Or we can combine. I don't know. Yeah, let's.
So that's very nice, because I know that in our database we didn't use the digital pathology, of course, because at the time we didn't really have, nobody had digital pathology. So pathologists, they are good pathologists, but they are still making some mistakes or variability, and then sometimes they say 2, sometimes it's 3, sometimes it's 1. So we know that this is not 100% perfect, and that's why we know that the machine cannot have a AUC 0.99 because there is always some kind of irregularity. But using digital pathology, it'd be really helpful.
Yeah, let's talk offline.
Yes.
Sometime. Yeah, okay, great. Thank you.
Thank you for the question.
Well, this has been awesome. Any last questions? We have a few
Yeah.
minutes left.
Yeah, I just wanted to clarify the remarks that I made when this was presented at the 2022 Banff meeting, and you have the link to the YouTube video of what I said. I was making an analogy between X-rays, radiology, deep fake radiology. And if you think about X-rays, they're just a picture in essence. And you can reverse engineer the X-ray completely. You can put in clinical data and make an X-ray that's as high resolution, that's indistinguishable from a real clinical X-ray. But, you know, biopsies are completely different. Biopsies are not just a picture, they're a piece of the patient. They're living, breathing, you know, flesh and blood. And you can apply 1,000 different ways of analyzing them. So that whole concept of reverse engineering the biopsy does not really exist. You can't reverse engineer everything. And so it is interesting, you know, this Richard Feynman quote, in radiology, you can argue now, radiologists understand better what the X-ray is because they can reverse engineer it completely. We'll never be able to do that, though, with the biopsy because, you know, we can't create a living piece of tissue like that exactly. Yeah. So that's what I was talking about at the time of your original presentation in 2022.
So right now there's one methodology called the generative adversarial network. Maybe you've heard of it. It's called GAN. I'm also working on it. But GAN is basically using all the data, and then the algorithm is quite specific, quite unique. But basically it generates data that looks like the one existing. So there's an application that you take photo, then it can make you like speak like Chinese, for example, but it's not really you. But it learns from your data, image data, that it can just generate like fake images and fake sound. So this is called the generative adversarial network, and then it is also being used slowly in the bio. So technically, we can replace it, but I don't want to say we can replace everybody. So.
Yeah, no, I predicted we would have that we would be able to reverse engineer light microscopic features of the biopsy by the 2024 Banff meeting, but we may not meet that deadline. Anyway, thank you. I've enjoyed your presentation very much.
Yeah,
Thank you.
Daniel. Okay, bye-bye.
Yeah.
Yeah, well, this is awesome. Well, I think, you know, I think we could go on for a long time because this is such amazing work, but I'm sure, you know, everyone has places to be. So we'll see everyone in 2 weeks, and you know, and thank you so much, Daniel. I really appreciate it. And we'll have this
Thank you very much for the invitation.
Yeah.
Thank you all
Bye-bye.
so much. You'll take care.
Yeah.
Yeah, great job. Yeah.
Take care. Bye bye.
Thank you.
Bye.
Thank you.